So I'm going to be talking with you guys today about the inhibitory learning model of exposure and its theory and application. And this is a topic that is a really big topic. So I know that we have 90 minutes to talk about this today. This could be a workshop that is done over the course of a week. So I'm going to, I have put together some components of this inhibitory learning model that I think are important for all of you to know in this webinar format. So first things first, I have nothing to disclose, no financial disclosures. And for our outline today, so first I will talk about the research behind the exposure, exposure and the inhibitory learning model and the research supporting this model, in addition to the theory, and do some explaining about how the inhibitory learning model is different from the emotional processing theory or the habituation model. And I use those terms interchangeably, so I'll say habituation and emotional processing theory interchangeably. They're the same thing, so that's what I mean when I'm talking about those. And I'll describe the differences between that habituation model and the inhibitory learning model, and then give you some more detail about those differences. And then we'll go into fear acquisition and extinction, because that's going to be an important component of the inhibitory learning model and how we use the inhibitory learning model. So it'll be important for me to explain to you guys how fear is acquired and also how we extinguish fear. And then we'll go into the inhibitory learning model, some more psychoeducation about it, and also its application for specific anxiety disorders, and then also give you some case examples at the end. Okay, so first we'll start with exposure research and theory. And I know this is a busy slide, but I wanted to get in all of this information before moving on. So the first thing here is that we know that cognitive behavioral therapy is the gold standard treatment for anxiety disorders. We have multiple meta-analyses that support this, that support its effectiveness. We have years of studies that support its effectiveness. So we do know that it's the gold standard treatment for reducing symptoms of anxiety disorders. And exposure, which is one of the behavioral components in CBT, is one of the key ingredients that is responsible for anxiety disorder symptom reduction. And traditionally, we have recognized that the key ingredient in exposure for anxiety reduction has been habituation, both within session and between sessions, from repeated exposure to a feared stimulus. So the habituation model, or the emotional processing theory model, has traditionally used habituation as being the marker of anxiety reduction and the marker of treatment success. So traditionally, what would happen is there would be a repeated exposure to a feared stimulus, to the same feared stimulus over and over, and the expectation would be that habituation would occur and that anxiety would reduce both within the session and between sessions. And new research suggests that, while habituation is effective in reducing anxiety, we know that it works. Learning theory, or in other words, the violation of expectancy, is just as effective, if not more effective. And when I say the violation of expectancy, what I mean is that our feared outcome does not occur when we are experiencing, symptoms of an anxiety disorder. So that, if you are experiencing anxiety, you have a feared outcome toward a stimulus, and the violation of expectancy would be that that feared outcome does not occur. So reduction, we also know that reductions in reported fear and physiological arousal throughout the habituation-based exposure is not necessarily strong evidence of corrective learning, and that efforts now should be more focused on the toleration of distress and the violation of expectancies over context and time, and this is designed to enhance new learning. So what we're not doing is we're not saying that exposure hasn't been working or that we need to make it better, because we know that it works. What we're saying here is we're just modifying the conceptualization of the mechanisms that underlie exposure. We're modifying the conceptualization of what are the active ingredients that really work in reducing anxiety disorder symptoms. So instead of having within and between session reduction of fear, we are now focused on the toleration of distress and the violation of negative expectancies. So here's a little bit more information about the emotional processing theory or the habituation model and how it compares with the inhibitory learning model. So first we'll go over the emotional processing theory column here. So in the emotional processing theory, researchers and clinicians say that fear has a structure that there is a fear structure in memory, that an individual with anxiety has a structure of fear stimuli in their memory, and that certain stimuli elicit different amounts of fear. And in this model, we consider habituation to be the critical index of change. And when we say habituation, we mean that there is a decreased response to repeated stimulation. And this decreased response to repeated stimulation is incompatible with the fear structure. So say, for example, you're afraid of flying and you have in your memory that, and in your mind that being on an airplane brings you really intense anxiety. So the goal would be to be on an airplane and have your fear habituate while you're in that situation. So you know that your anxiety decreases and that being on an airplane no longer is associated with intense anxiety. And now that the airplane would be associated with calmness rather than with anxiety is incompatible with the initial fear structure, and therefore corrective learning occurs. So these non-fear-based elements replace and compete with the initial fear-based associations. And that is why habituation is the critical index of change, because that habituation to the feared stimulus is needed in order for that corrective learning to occur, that the initial feared stimulus is not paired with high distress. And the way that we measure distress in the emotional processing theory is with the utilization of SUDS. So that those are subjective units of distress. And SUDS are typically rated on either a 0 to 10 or 0 to 100 scale, depending on the clinician, it doesn't matter. And the clinician would ask the patient, what are your SUDS ratings? How distressed are you when you are confronted with this feared stimulus? And the SUDS are asked repeatedly during the course of the exposure, with the necessity of the SUDS reducing, therefore indicating habituation. We also have behavioral measurements. So those are things like, is the patient leaving the room? Are they shaking? What do they look like behaviorally? And then physiologically, there are physiological measurements as well, which are things like measuring heart rate, skin conductance, and things like that to indicate habituation. So with the inhibitory learning model, we are conceptualizing fear as being acquired. So what we are saying here is that there is a CS, or a conditioned stimulus, so which is initially a neutral stimulus, and I'll get into more detail, I think, on the next slide about this, is paired with an unconditioned stimulus. And an unconditioned stimulus is a stimulus that automatically elicits a response that we would have a response to, and it becomes paired with this neutral conditioned stimulus. So therefore, learning occurs. So for example, this conditioned stimulus that was once a neutral stimulus, maybe it's a person, for someone with social anxiety, the conditioned stimulus could be just like a person or a group of people, now equals danger. So for example, intense anxiety or social rejection or a dog bite, could be anything, and then generalizes. So the focus here is on new learning that inhibits old learning. So the new learning that we focus on in the inhibitory learning model is a toleration of distress and a violation of negative expectancies across time and context, and also an element of surprise. So what we're trying to do in the inhibitory learning model is present the conditioned stimulus in the absence of the unconditioned stimulus over time and across contexts to enhance new learning. And then there is this element of surprise that's really important too. So if, for example, you have somebody with social anxiety disorder who expects that when they go hang out with their friends in a group that there's going to be some form of social rejection, or there might be a really intense level of anxiety that they believe they won't be able to tolerate. And then if they learn in that context that no social rejection occurs, then there's this element of surprise, like, oh wow, what I thought was going to happen didn't happen. And that element of surprise is so important because that will help to highlight the violation of the negative expectancy and the toleration of distress. We focus on whether the feared outcome occurred or didn't, and whether distress was tolerated. And the key part here that I think can be surprising to some is that no habituation is needed, and we don't care about SUDS ratings. So typically in session, when we used to do exposure with the emotional processing theory, we really didn't want to have a client leave the session without having a habituation in their and a decrease in their SUDS ratings. And now we actually don't care. We can have somebody have really intense distress in the beginning of session, in the beginning of exposure, and still have intense distress when they leave. What we care more about is the focus on the articulation that the client can give us of their new learning and this element of surprise. Okay, so now here we go into fear acquisition and some classical conditioning. I think there are only 3 slides on this, I promise. So I'm going to start out really basic with the Pavlov's dogs example, which I'm sure several of you already know about. So we have here an unconditioned stimulus, and an unconditioned stimulus, or the US, is a stimulus that naturally and automatically elicits a response. So in that classic example with Pavlov's dogs, we have dog food. Dog food is an unconditioned stimulus because it automatically will elicit a response from dogs. Okay? And then we have the unconditioned response, which is an unlearned response that occurs naturally in response to the unconditioned stimulus. So in this example, again, the unconditioned response is salivation to the food. We have this unconditioned stimulus, which is dog food, and then the salivation to the food is the unconditioned or unlearned response. A conditioned stimulus is a previously neutral stimulus. A previously neutral stimulus that, when paired with an unconditioned stimulus, begins to elicit a conditioned response. And I just saw a comment pop up that it was actually a bell. I apologize. I put that it was a light, but for the purpose of classical conditioning, I think it's okay here. So the conditioned stimulus, whether it was a light or a bell, it was paired with the food, and then the light or the bell becomes conditioned to signify food. And the conditioned response is a learned response that occurs in response to a conditioned stimulus. So eventually there is salivation to either the light or the bell. And the order of the presentation of the conditioned stimulus is also really important. So if a light is paired with the food, the light has to come before the food in order for that pairing to occur. So if the food came before the light, that pairing would not occur. So when we apply this to social anxiety, for example, our unconditioned stimulus would be social rejection. That is a stimulus that automatically elicits a response. Social rejection doesn't feel good, nobody likes it. The unconditioned response could be distress, anxiety, or amplification of physiological symptoms, maybe heart racing, sweating, or blushing. And the conditioned stimulus here could be the person who rejected you and eventually other people. The conditioned response would then be anxiety, the amplification of physiological symptoms like the heart rate or the blushing or the sweating when confronted with people, even in the absence of being rejected, because this learning has occurred. There was a pairing with a particular person or group of people with the social rejection. And this is how, based on this model, we conceptualize that social anxiety disorder is developed. So fear generalizes. So not only does the socially anxious individual fear the initial person who rejected them, but other people as well, due to the possibility of this rejection or of the unconditioned stimulus happening. And learning occurs. So this patient who has been rejected socially will then start to associate all social interaction with the possibility of being rejected, experiences an elevation of anxiety, and then may avoid social interactions or engage in behaviors that help to avoid social interaction. And then we have fear extinction. So what is also important here is to learn how we extinguish fear once fear is acquired. So in order to extinguish fear, the conditioned stimulus must be presented in the absence of the unconditioned stimulus repeatedly across contexts. So we want there to be the presentation of this conditioned stimulus. In social anxiety, it would be people, in the absence of the social rejection, or in the absence of this fear that intense anxiety can't be tolerated. It totally depends. I'll get into that later. And we want that to be repeated across contexts and over time. So thus, this person no longer would associate the conditioned stimulus with the unconditioned stimulus, and then over time, the fear becomes extinguished. So with the Pavlov's dogs example, if the light is presented or the bell is presented without the food repeatedly, the dogs won't continue to salivate to the presentation of the light or the bell. And with social anxiety, if people are presented in the absence of social rejection, the socially anxious individual won't associate people with rejection and will no longer be anxious in social situations. So this is what we're trying to do here with the inhibitory learning model. Okay. So getting into more about this model, so you have some background now. So because we don't really care about habituation anymore within the session and also between sessions, we now use this inhibitory learning approach. And as I mentioned before, we have learning that occurs when a conditioned stimulus is paired with an unconditioned stimulus. So we learn that this conditioned stimulus is paired with some form of discomfort. So when we start engaging clients in exposure, we want them to be repeatedly confronted with the conditioned stimulus in the absence of the unconditioned stimulus. Okay. So what we are hoping is that when the conditioned stimulus is presented in the absence of the unconditioned stimulus across time and across contexts, that this conditioned stimulus now becomes an ambiguous stimulus that has two meanings that compete for retrieval. Okay, so we have this new learning that the conditioned stimulus no longer equals the presence of the unconditioned stimulus. That's the new learning. And the old learning is that the conditioned stimulus is associated with the unconditioned stimulus. So our hope is that the new learning is retrieved and inhibits the old learning. Sometimes the old learning is retrieved, which then signifies a return of fear. That's a topic for a whole nother webinar. But for the purpose of this talk, we are hoping that the new learning, that the conditioned stimulus no longer predicts the unconditioned stimulus, inhibits the old learning, and therefore fear is reduced. So in the habituation model, again, we want the fear to reduce during the exposure to know that it's working, because habituation is that key ingredient. And in the inhibitory learning model, we actually don't really care if fear reduction occurs in session, and it doesn't need to occur to signify that learning is occurring. And instead, we want our patients to articulate that the stress was tolerated and or the feared outcome did not occur. And on the off chance that the feared outcome does occur, that the patient can tolerate it, can tolerate the distress associated with that. So the key ingredient here is that new learning occurs for the toleration of distress and the violation of negative expectancy. And it's really, really important that we have our patients articulate that they could tolerate the distress and whether their feared outcome occurred or not. Okay, so the three main goals here. The goals of the inhibitory learning model, that one, distress and anxiety can be tolerated. Two, that the feared outcome is unlikely to occur. And three, that if the feared outcome does occur, distress can be tolerated. Okay, so now getting into a little bit more about avoidance, and I think that this is the last slide prior to actually getting into how we do this. So it's important to discuss avoidance here. It's important to discuss avoidance with your patients. Avoidance is a really major factor that maintains anxiety. So we have here that avoidance must be targeted during exposure because it is that major factor in the maintenance of anxiety. And avoidance provides short-term relief and maintains long-term anxiety. So an example would be, say you have somebody that is really anxious about going into the grocery store, right? Whether it's due to social anxiety or maybe it's due to being in a crowd. And just all of my examples will be pre-COVID examples. So if you have somebody who's afraid of going into a crowded grocery store, they drive to the grocery store, they notice that their anxiety starts to increase, they get out of their car, they go into the grocery store, and their anxiety skyrockets. They notice that their anxiety skyrockets, it's really uncomfortable, so they say, nope, never mind, I'm out, and they leave the grocery store, and they go to their car, and they go home. That feels really good in the short term. The anxiety immediately reduces when they leave the grocery store and when they go back into their car and go home. But what happens the next time they have to go to the grocery store? Their anxiety does the same exact thing. They drive to the grocery store, a couple of days later, they go into the grocery store, their anxiety spikes again. So while avoidance feels really good in the short term because it immediately reduces the distress, it maintains long-term anxiety. And this is a really important component to make sure that you share with your clients, because to clients, avoidance feels really good. And biologically, avoidance makes sense, right? Our bodies, our brains are telling us to flee in danger. And however, this is not the answer for reducing anxiety, because by avoiding, an individual will never learn that they can tolerate the distress associated with their fear, that our patient will never learn that they can tolerate the distress associated with going into the grocery store, or that their feared outcome of being in the grocery store is unlikely to occur. And also, people can become really dependent on avoidance, and then their lives can become really small because they're avoiding lots of different things, and then their quality of life reduces. So initially I was going to show you guys a YouTube video. That's why there's a YouTube link at the bottom of this slide. Due to technical difficulties, I can't show you the video, but I know that you all have a copy of these slides. So if you're interested, you can copy and paste this link or type it into a web browser and watch this YouTube video. It is about a 3.5-minute video that really nicely describes avoidance and how people can become dependent on avoidance, but it's not essential for my presentation right now. Just if you're interested, go ahead and look at that later. All right, so now we're going to switch gears a little bit and go into the actual application here of the inhibitory learning model. So there's a lot of psychoeducation that I'm going to give you guys, and also that is important to give to your clients, because when we are going to be doing exposure with our clients, we are going to ask them to do stuff that they are really afraid of doing, right? We're going to ask people to face their fears and engage in activities that are really scary to them. And so it's really important to highlight a lot of the psychoeducation that I'm going to go over with you now. So first, what's important is to provide psychoeducation about anxiety and specific anxiety disorders, just to kind of normalize what they're experiencing, and also to give them some information about anxiety, what anxiety looks like, and then specific anxiety disorders that would apply to them. And then go over avoidance. So similar to my previous slide, I would tell clients that avoidance is a natural response to situations that are perceived as threatening, that it totally makes sense that we would want to avoid things that make us really distressed, but that too much avoidance interferes with functioning and it prolongs anxiety in the long term. That avoidance provides short-term relief, maintains anxiety in the long term, as I just mentioned. And I always provide an example. I just gave you guys that grocery store example. It depends. I tailor my examples based on the specific presentation of the patient, but this is another example that can be used. So say someone who was afraid, say you know someone who's afraid of swimming in the ocean. They were so afraid that not only did they never swim in the ocean, but they also didn't go to the beach, swim in a pool, or even watch movies where people swim. And this avoidance impacts their quality of life and also keeps them from learning that they can swim in the ocean safely. And usually what I would do there after providing that example is I would ask the patient, okay, so what would you recommend to this person that you know who's afraid of swimming in the ocean to help them get over their fears? And they usually are able to come up with a response that's like, we would have them go swimming in the ocean or approach water in some way, or they kind of get the idea of where we're going with this. And then providing education about exposure therapy is really important. So telling the client that they are going to work on confronting situations and sensations that they avoid, to learn that negative outcomes don't always occur and that anxiety can be tolerated. And depending on the client, you may need to spend more time here or less time here. Sometimes you have clients that are really motivated, that really get it, and you can kind of jump ahead. And then you have other clients who are, who need some more time with the rationale and understanding why this is something that's going to work for them. Okay. So more psychoeducation. There's a lot of psychoeducation that needs to be done here. So I then, would discuss safety signals and behaviors. And safety signals are another form of avoidance, but they are not often easily recognized as avoidance. So when we think about safety signals and behaviors, we think about anything, so like any things or people or situations or behaviors or thoughts that actually reduce our anxiety because they are present. So they are called safety signals because these things, so these objects or behaviors or thoughts or situations, make the client feel protected from the thing that they dread. So clients will have safety signals or safety behaviors that, when they are present, actually reduce the client's anxiety when confronted with their feared stimulus. So they associate an anxiety reduction to this thing, this object, this thought. And it might make the clients think that it reduces the chances of the negative outcome occurring just solely by having this thing. So here are some examples. So someone who has panic disorder might bring their bottle of Ativan with them wherever they go, maybe when they drive or when they go into certain situations, because it reduces their anxiety. Not that they even take the Ativan, but just that having the bottle of their Ativan with them in their car, in their purse, or something like that helps reduce their anxiety in certain situations. And in this case, they won't actually learn that they can either drive safely or go to the gym or go into crowds or something like that, even if they are feeling panic symptoms, because they are associating their reduction of distress or their safety with this Ativan bottle. Some other examples of safety signals or behaviors could be like bringing a water bottle, a patient bringing a water bottle with them wherever they go, or having like someone who has maybe a fear of driving, like a driving phobia, would have like a little like bobblehead or something on their dashboard that makes them feel calmer when they see it there. Something, and it can be a variety of things, and it's important to assess that with your client. Variability of exposure is also really important. So exposures need to be done in a variety of different contexts because we want the learning to generalize across contexts. So doing these exposures in different settings because this increases potential for learning, and also attentional salience. So we want the client to focus their attention on the feared stimulus. Okay, we don't want them to be focusing their attention on something else. So if you have a client who has social anxiety disorder and one of their exposures would be to, have an in-person meeting with a boss or with a coworker or a friend, you want them to be focusing on the conversation and on the person that they're talking to be able to test out their feared outcome. We don't want them to be like thinking about what they're going to do later or, like looking at the wall behind the person. We want them to be paying attention to the feared stimulus. Okay. Okay, so assessment. So this is going to be crucial in helping to design exposures with your clients. So this is an exposure assessment that needs to be done prior to coming up with an exposure list or assigning exposures. And this is going to be something that helps you gather a bunch of information in a variety of different areas that will help you and the client together build exposures. So in this assessment, the first thing that's so important, probably the most important thing to ask is, what is your feared outcome? What is the client's feared outcome? Because without this feared outcome, expectancies can't be violated. Okay, if we don't know what the person is afraid of, we can't test it out. So some examples of a feared outcome could be, that someone will have a heart attack and die, or social rejection, or an intolerable level of distress that lasts forever. It totally depends on the individual. And sometimes someone will just be able to articulate that an intolerable level of distress is the feared outcome. So like, I'm going to experience so much anxiety that I won't be able to function, and that anxiety is going to last the whole entire day. And if that's the feared outcome, that's okay. It may not be something like a heart attack or social rejection or a dog bite. It might be that there's just this really intense level of distress, and that the distress is going to last forever. Physical sensations are really important to assess. So what physical sensations make the person anxious? It could be like an increased heart rate, dizziness, blushing, feeling faint, sweating, chest pressure. Could be a variety of things. Situations and settings that increase anxiety. So where do they get most anxious, or anxious at all? So maybe when they're doing exercise, or in a crowded place, or in small spaces, on an airplane. So assessing what situations and settings would increase the patient's anxiety. Feared thoughts and images. So could be the image of having a heart attack, or the image of, having to call an ambulance and having the ambulance take them to the hospital, or an image of everyone laughing at them, or the thought, I'm going to die. Safe places could be home, near the hospital. Could be things like, driving on local roads instead of the freeway, or driving a certain way to work. Safety objects, which are those safety signals that I talked about previously. So anxiety medication, a water bottle, a cell phone for social situations to always look like you're busy. And then finally, duration. So how long does the client need to experience these feared physical sensations, or situations, or objects, or thoughts until they are convinced that the feared outcome will occur? This is going to be important to help decide how long you're going to have them engage in the exposure for. So for example, sometimes a social anxiety client might say, I can go to a gathering for 30 minutes, but after that 30 minutes, I can't do it anymore and I leave. Or, I can experience a racing heart while I'm working out for 5 minutes, but as soon as that 5 minutes passes, then I'm afraid that, I'm going to have a heart attack. So it's important to assess the duration of how long the client feels like they can experience these feared situations or sensations or thoughts until they think that the feared outcome will occur. Okay. So moving forward with more assessment. So I threw this in here because it's important for panic disorder to also do an interoceptive assessment. So you're not always going to have a panic disorder client, but if you do, then an interoceptive assessment is important to do. So you will also need to conduct one of these assessments in addition to the exposure assessment prior to developing the exposure list. And this will help to assist in choosing sensations that elicit distress, and also sensations that are similar to the sensations that people experience during one of their panic attacks. So panic attack symptoms are below here, and they are palpitations, pounding heart, accelerated heart rate, sweating, trembling or shaking, shortness of breath or sensations of smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or hot flashes, numbness or tingling sensations, and derealization or depersonalization. And someone having a panic attack can have a variety of combinations of these symptoms. So on the slide following this one, I'm going to talk about the different interoceptive exercises that we would have a client do. But the client should perform each of the activities that are on the next slide for at least 1 minute. And following each exercise, you would have your client rate their level of distress on a 0 to 10 scale, and also how similar the sensation was to the actual panic sensations on a 0 to 10 scale. And I just want to differentiate here. We're not trying to assess, their SUDS ratings based on an exposure. What we're trying to do is we're trying to rate their distress while doing this interoceptive assessment to determine which exercises we're going to pick to put on their exposure list. And also we're going to have them rate their sensations to determine how similar the sensations are to their sensations when they actually have a panic attack. So as the clinician, you either want to model each exercise prior to the client practicing them, or what I like to do is I like to do the interoceptive exercises with the client at the same time. Either one is fine. You can take a break of 1 to 2 minutes between each exercise. And subsequent exposures that you develop with the client will include the exercises rated as at least moderately distressing and at least moderately similar to an actual panic attack. So I would say like a 4 or above. Here are the exercises. So these are definitely interesting and sometimes not so fun to do with your client. So we would have, because I would do it at the same time. So spinning helps to elicit dizziness. Then there's straw breathing with the mouth closed and the nose plugged. Sometimes an actual straw can be too wide. So using a coffee stirrer also works well. Those are really small and really help to elicit shortness of breath. Hyperventilation, and then running up and down the stairs or in place, anything to elicit an increase in heart rate, depending on the fitness level of the person, jumping jacks, burpees, whatever you can think of and the person is willing to do and will increase their heart rate. And also staring at self in the mirror to elicit the depersonalization. Okay, so now once we've done all of that assessment, so the exposure assessment and also the interoceptive assessment, if needed, based on the diagnosis of the patient, you would then build an exposure list. So typically we think of this as a fear hierarchy, right? So when we would do exposure using the other model, we would build a fear hierarchy, but we call this an exposure list because this isn't actually a hierarchy. So we are using factors gathered earlier in our assessment to develop a list of potential exposures. And the exposures will be selected at random from the list when you start assigning them, and no hierarchy is needed. So you don't need to, when you are building this exposure list, ask for SUDS ratings as you are going through the exposures. And then once you start to begin assigning exposures, you create the list, and then you start assigning exposures, and you always want to do the first one in session with your client. And as I mentioned previously, we want to assign exposures at random, but we also, especially for the first exposure, we want to, we want to use our clinical judgment and set the client up for success. We do not need to go from a low SUDS rating to a high SUDS rating when we pick, because we don't actually know their SUDS ratings. We can choose any exposure from the list to begin violating expectancies. I currently have a supervisee who has developed this really cool exposure randomization tool that she has developed for her computer, and I'm going to try to get access to that, where it like spits out random exposures once you put in the list. Exposure should be done during session and at least 3 times for homework. And I say this because I go into, the session, and when I assign homework, I say, I want you to do exposures every day for homework. If they say, sure, I'll do it every day, great. But I'll take 3 times if someone says every day is too much. And we want our clients to complete the exposure in a variety of contexts to maximize new learning. We don't want them to do the same exposure in the same place at the same time every single day, or for 3 times. We want them to vary it up. Okay, so more on the assignment of exposure. So the first exposure should set the client up for success using your clinical judgment, as I mentioned before. And it's also feasible to do in session because we want to make sure that we do our first exposure during session. So for example, if you have somebody who is a client with panic disorder, you may have them hyperventilate for 75 seconds while focusing on the image of having a heart attack. And you may pick 75 seconds because they may say to you that, they can only tolerate it for a minute, for example. And because this is such a short exposure, 75 seconds is not super long, ideally you would then do the exposure 2 to 3 times during session. You don't want to just do it once. So during the exposure practice, you always want to talk about the non-occurrence of the feared event and have your client articulate the non-occurrence of the feared event. And you will ask targeted questions to have them be able to articulate the non-occurrence of the feared event. And I'll get it, and I have more examples later of those questions. So asking the client, did you have a heart attack? Were you able to tolerate the distress of interacting with new people? How do you know? And again, making sure that the client is the one who's articulating. We don't want to give them the answers because learning will not occur that way. And always assign between session practice because homework is a must. We know that homework directly relates to outcome. I would give clients examples of why homework is so important. Sometimes I give an example of like learning to play a musical instrument where, of course, like if you want to learn to play the violin and you practice once a week, great, you're going to learn how to play the violin. It's going to be a lot slower though than if you practice multiple times throughout the week. Same thing with going to the gym. If you want to build muscle, you'll build muscle once a week if you go to the gym. You'll build muscle a lot faster if you go more than once a week. So the aim is for daily practice, but as I mentioned, I'm okay with 3 days. It's up to you. And if an exposure is brief, like the 75 seconds of hyperventilation, it should be conducted at least 3 times within a short period of time. You want to discuss the details of the exposure practice with your client, including how long they're going to do the exposure for, the number of repetitions, the context, and most importantly, what is it that they're testing out? What expectancy is the client going to be violating? And especially when you're assigning homework, it's so important to make sure you save time at the end of session to really work out all the details before sending them on their way, because this is going to be important in terms of how they actually do the exposure at home. And you always want to have a worksheet that you do with them or that you have them complete before the exposure, after exposure, and have them take it home with them as well. And I'm going to go into those now. Okay, so here are some questions that you want to make sure you ask before the client engages in exposure. These are questions to ask while you're in session, and also you can put these questions on some form of worksheet for the client to be able to take home. Now that we're all doing virtual therapy, maybe you put these on a Google Doc or send them via email or something like that to your client. And you can develop any kind of worksheet you want. These are the questions that I like to ask, and these are the questions that are important to highlight for before the exposure is done. So you always want to ask the client, what am I testing out? What am I doing here in the exposure? What am I going to be testing out? What feared outcome am I most worried about? Or what am I worried I will not be able to tolerate? And have the client write it down. how am I testing it out? So what am I actually going to do in the exposure? What are the situations? What are the settings? Am I going to be leaving my safety behavior, safety object behind? What exactly am I doing to test it out? And how likely is it that what I'm most worried about will occur? How likely do I think it is that my feared outcome will happen? 0 to 100. 0 is not at all. 100 is certain. Then you would have them do the exposure either in session or at home after filling out those questions. Then when they're done with the exposure, you want them to immediately fill out these post-exposure questions or answer them if you're in session. How long was the exposure practice? How long did I do it for? Did what I was most worried about occur? Yes or no? Did my feared outcome happen? How do I know? What did I expect to happen as a result of doing the exposure? What happened? And did that surprise me? What did I learn? And imagine that I repeated the same exposure practice again. How likely is it that what I was most worried about before will occur this time? So, and usually we rate this on a 0 to a 100 scale as well, asking the client, if they were to do the same thing, how likely do they think it is that their feared outcome will happen this time? Okay. So now I'm going to get into, we're getting closer to the end of my talk here. I'm going to give you some case examples, one for social anxiety and one for OCD, and then we'll have plenty of time for questions. But I'm going to walk you through case examples here, going through the assessment and the exposure list, exposure assignment, and exposure worksheet pieces for each of these cases. So for the social anxiety case, so we have Tom. Tom is 29. He's presenting to treatment due to anxiety in social situations. Tom owns a small business and has a business partner. Although he experiences anxiety asserting himself and his ideas for the business due to fear of judgment and rejection by his business partner. Tom has a small group of friends and he feels comfortable hanging out with them one-on-one. However, he typically avoids going to group gatherings or leaves early if he does attend. Additionally, Tom said that he would like a romantic relationship, but he avoids dating situations. So again, I'm going to say these are all examples for pre-COVID. And with social anxiety now, due to COVID, we have to get a little bit more creative with our exposures. All right, so if we were going to do an assessment with Tom, so we would ask Tom, what is your feared outcome? What are you afraid is going to happen in social situations with, in group gatherings or when you're talking with your boss, or not with your boss, with your business partner? And his feared outcome would be social rejection or judgment. And when we are assessing the feared outcome here being social rejection or judgment, and when we start assigning exposures to test out whether judgment occurs or not, I'll get into this a little bit later, but it's really important to behaviorally describe what judgment looks like to our client, because judgment's pretty ambiguous and sometimes we have absolutely no idea if someone's judging us or not. So it's important to behaviorally describe when you're in a social situation, how do you know that someone's judging you? And it could vary from person to person. It could be like an eye roll, a furrowed brow. It could be like saying something. So that's also really important to behaviorally describe what that looks like. His feared physical sensations could be racing heart, a flushed face and sweating, situations and settings, conversations with business partner, group gatherings, dating situations. So things like online dating, sending messages online, or introducing himself to women. Feared thoughts and images. They think I'm stupid and weird, or image of others quietly rolling their eyes at me. His safe place is at home by himself. Safety objects and behaviors, always having his cell phone around, drinking alcohol, either when he's in a group gathering or prior to going to a group gathering. And Tom stays in group gatherings for 45 minutes max, and then he leaves. So here's a potential exposure list that we could come up with for Tom based on the assessment that was just done. So his exposure list, he could have a conversation with his business partner, have a conversation with his business partner, making a suggestion about a change in the business, sending a message via an online dating platform, introducing himself to one new person in a bar, again, pre-COVID, going to group gathering with friends and stay for 1 hour, since his duration is 45 minutes typically, go to group gatherings for 1 hour while blushing. Okay, so we have a tool sometimes that we can use in social anxiety exposure. So the vitamin niacin, if the client is willing, you can have the client take it, and it actually induces facial flushing. So it can be similar to blushing when the client is actually going to a social gathering. So that could be useful for exposure if they are willing to do that. Have a conversation with business partner after spraying himself with water to mimic sweating, right? Having a spray bottle and like spraying his face and his body. Increase his heart rate prior to going to a group gathering and stay for at least 1 hour. So doing something like running in place or like jumping jacks or something before going to the group gathering. Join a group like Toastmasters and introduce himself to 2 others. Make a phone call and ask a silly question. So when I say make a phone call and ask a silly question, sometimes I'll have clients with social anxiety, call Home Depot and ask like, what kind of cheese do you sell? Or something like that. So making a phone call and asking some sort of question that does not apply at all to the place that they're calling. Or calling a restaurant, making a reservation, and then immediately calling back and canceling the reservation or something like that. Okay, so for the exposure, say we picked one of those exposures from the list, and we picked have a conversation with his business partner, making a suggestion about a change in the business. Okay, so this would be the exposure, either the pre-exposure worksheet, sorry, however you want to develop it, asking these questions. What am I testing out? So Tom would say, my business partner will have a judgmental face. He will roll his eyes, have a furrowed brow, and tell me that my idea is stupid. How am I testing it out? I'm going to meet with my business partner and suggest that I shift my work hours. I'm going to pay attention to his facial expressions and his response to my suggestion. And when rating, how likely is it that what I am most worried about will occur? So when rating the likelihood of his feared outcome, Tom rated an 85. So pretty high, right? Pretty certain that he's going to get rejected or judged for this interaction. So then Tom would go and do the exposure. And here are the post-exposure questions. So maybe he had a meeting with his business partner for 15 minutes. And then, did what I was most worried about occur? No. How do I know? I met with my business partner and suggested a change in my work hours. He did not roll his eyes or furrow his brow. He told me we could continue the discussion about changing my work hours based on the needs of the business. He did not tell me my idea was stupid. What did I expect to happen as a result of doing the exposure? What happened? Did that surprise me? And remember, we have that element of surprise in there as being something that we want to assess for. I expected that my business partner was going to roll his eyes and furrow his brow and tell me that my question was stupid. He did not roll his eyes or furrow his brow. He told me we could continue the discussion about changing my work hours based on the needs of the business. He did not tell me my idea was stupid. That surprised me because I really thought he was going to judge me. What did I learn? I learned that I can talk to my business partner about a suggestion and he won't judge me or tell me my idea is stupid. And so also I want to say here that this is kind of like an ideal outcome to the exposure. And if you guys have questions about what to do if the exposures don't go as well, I can answer those. Imagine I repeated the same exposure practice. How likely is it that what I was most worried about before will occur this time? And he rated it a 60, which is still high. It's less likely, but still not sure. And so before I go into the next example, which it would be an OCD client, I want to just point out that this is a lot of work, right? Like this is a lot of work for our clients to do. Like we're not only asking them to do the exposures, which are really scary, we're also asking them to fill out a bunch of paperwork and to answer a lot of questions. So that's why it's so important to highlight the rationale of why we're doing this and also get their buy-in. And sometimes we have to revisit the rationale and revisit the motivation and the buy-in for doing this because it does require a lot of work, like during every exposure to have them fill out this paperwork, especially when they're at home doing homework. It's easier in session. Okay. So finally, we have a case example for OCD. I wanted to pick social anxiety and OCD because I think those are, really common cases that we see. And also this can be applied to all of the anxiety disorders. So again, if you have specific questions about a different anxiety disorder, you can ask them in the chat, or I can give my contact info at the end and you can contact me about those questions. So for OCD, okay, so Amy's a 21-year-old female presenting to treatment due to contamination fears. Amy fears that if she touches high-touch surfaces, so like elevator buttons or doorknobs, she will contract a life-threatening illness. And I feel like I keep having to say pre-COVID because during COVID, this actually kind of makes sense. Amy relieves her anxiety by avoiding touching high-touch surfaces. She uses Q-tips, tissues, and gloves to touch surfaces. And when she doesn't have access to one of these methods, she uses hand sanitizer or washes her hands several times until she feels just right. So here is Amy's assessment, her exposure assessment. So her feared outcome is an intense, intolerable anxiety or the development of a life-threatening illness. So for Amy, it's more so that she's afraid that a life-threatening illness will happen in the future. So there's this intolerance of uncertainty component here. So her feared outcome for in the moment exposure is more likely going to be the intense, intolerable anxiety associated with this unknown of contracting a life-threatening illness that she fears will make it so she can't function and that it will last forever. Physical sensations, she experiences a racing heart and butterflies in her stomach. Situations and settings, touching high-touch surfaces like doorknobs and elevator buttons. Her feared thoughts and images are, I'm going to get sick, this is dangerous, this is disgusting. Her safe places are at home. Her safety objects and behaviors would be to always have rubber gloves with her, or tissues to open a doorknob, or Q-tips to help push with the elevator buttons, because she works in a building that has several floors that require an elevator to get to her office. And her duration is really short, 5 seconds. So here's an example of an exposure list for Amy. So Amy could touch a public doorknob with her bare hand for 10 seconds, since her duration was 5 seconds, and use hand sanitizer once instead of as many times as she needs to feel just right. Touch a public doorknob with her bare hand for 10 seconds and do not use hand sanitizer or wash her hands at all. Touch a public doorknob with her bare hand and then touch the side of her face. Touch 3 buttons in the elevator and do not use hand sanitizer. Touch 3 buttons in the elevator and use hand sanitizer once. Touch public doorknob with bare hand, then press the elevator button while focusing on the thought, I'm going to get sick. So there can be a lot of variation here in what you do with these exposures. Okay, and here's that pre-exposure worksheet again. So we'll pick the exposure, touch a public doorknob with her bare hand for 10 seconds and do not use hand sanitizer or wash hands. So what is it that she's testing out? I will not be able to tolerate my intense anxiety about getting sick, and the anxiety will last forever. How am I testing it out? I'm going to touch the doorknob at a Starbucks for 10 seconds and not sanitize or wash my hands afterwards? And how likely is it that what I'm most worried about will occur? So she said a 90. So she's really, she thinks it's really likely that she's going to experience extremely high anxiety that will make it so she can't function, and it's going to last a really long time. You would have her then go do the exposure, post-exposure questions. So how long did she do the exposure? 10 minutes. So since the exposure itself, the individual exposure was only about 10 seconds, you would have her do it multiple times with, taking maybe a minute break in between to last for a longer duration. Did what I was most worried about occur? No. And how do I know? I touched the door at Starbucks for 10 seconds several times. My anxiety got really high, but it did not last longer than a few minutes. I was also able to continue talking to my friend and text her on my phone. I don't know if I'll get sick in the future, but I know that my anxiety did not last the entire day. And what did I expect to happen as a result of doing the exposures? What happened? Did that surprise me? I expected that I would get so anxious that I would start crying and not be able to stop. I also thought that my anxiety would last the entire day. It surprised me that my anxiety got really high, but I was still able to talk to my friend and use my phone. My anxiety didn't last the whole day. What did I learn? I learned that I don't immediately contract a virus and that I can function despite intense anxiety because I was still able to, text on my phone and talk to my friend. My anxiety also didn't last as long as I thought. So imagine I repeated the same exposure practice. How likely is it that the feared outcome will occur the next time? And she says 50. Okay, so I think, yes, okay. So that is my last slide for the talk. So let's see, it is now 1:10. So we have some time for questions.
Okay, awesome. Thank you so much, Dr. Lawrence. I'm gonna jump on here and let's go ahead. I'm gonna get through all these. You guys are asking really great questions, but I'm gonna go ahead and just ask the one that you kind of already mentioned, which is how do you handle it if the feared outcome does occur in an exposure?
Yeah, so if the feared outcome does occur in an exposure, it's going to be about focusing on, were you able to tolerate this feared outcome, right? So if they did engage in a social anxiety exposure and they did have a really negative experience and someone maybe said something to them that was really mean or judged or had some behavioral indicator of judgment, you would then focus on, how do you know that you got through it? Did you crumble in the moment? Did you combust? Did you fall to the floor? Or did it suck, but you managed through it? Were you able to tolerate it?
Okay. Next question is, if the client is focused on the goal of anxiety reduction, so like they come to treatment for anxiety reduction, but not tolerating anxiety, how do you increase buy-in for exposure therapy? And is it reasonable for them to expect a reduction in fear or anxiety over the long haul if their tolerance increases?
Okay, so the question is, if somebody, I just want to reiterate it. So if somebody comes in and their goal is fear reduction, how do you get buy-in to not actually, okay, noticing fear reduction? So I would get buy-in by telling the client that the goal actually is fear reduction over time, right? Like, we're not just doing this to maintain a high level of fear the whole time. By doing these exposures and through new learning, your anxiety will decrease over time. We just don't care as much that your anxiety is going to reduce like right now. We don't care that it's going to reduce in the next 50 minutes. But the goal is actually fear reduction over time. And we have measurements of fear reduction over time, right? Like, we give questionnaires. We also have that rating at the end of doing an exposure. How likely do you think your feared outcome will be next time? As those ratings get lower, that's also indicating fear reduction. So I would explain to the client that ultimately your goal is fear reduction. We want you to feel better. We want your symptoms to go down. It's just that you won't necessarily experience fear reduction in this next 45 minutes.
Got it. That makes sense. Okay, do you ever have someone act as an observer during social exposures to ensure that an objective perception of what occurred is elicited? So I have a lot of patients who may perceive that someone is furrowing their brows, thus not violating the expectancy, even though it may be a bias in perception of reality. What other ways have you managed this?
That's a really good question. I've actually, I've never had someone go as an observer, but I would be interested in having a
I've done it
conversation about
before where
that.
like,
Have you?
yeah, I've done it as like it, pre-COVID era, but like if you're doing something, yeah, like kind of going to Starbucks or something like that, I'll kind of be an
Oh,
observer and like, but like stand back, I'm not going to be like right next to them. So I have done that, but yeah, I think that's a really good question because
that
there
is,
certainly
yeah.
is some evidence of, yeah, perception being altered.
Yeah, yeah, yes, like in session exposures pre-COVID, like I would do that as well, especially when I was in graduate school at UCLA, like I would kind of follow behind the client when they were doing social anxiety exposures around campus and stuff like that, and I would be an observer, but I'm trying to think about, for when they're doing exposures for homework, like how to facilitate that accurate, the accurate description of judgment or something like that. That's interesting.
Yeah, I like that one.
Yeah.
Um, yeah, I think there's a lot of things you could do, like even it would depend, but in some situations like video recording or like audio recording so they can go back and review maybe.
Mm-hmm.
That's a good one.
That is a good one.
Okay, I'm kind of jumping around because I want to get through some quick ones. So how do you
Yeah,
deal with resistance with homework into the treatment process?
that's another good question. I would really go back to highlighting the rationale and how important it is and why it's so important. And if you have somebody who's really resistant to homework, I mean, you know, I would still do exposure with them in session and still assign homework. And if the homework isn't completed, kind of this is more like DBT, but do a mini chain about why the homework didn't happen or like what's getting in the way or assess the barriers to completing homework and then really fall back on the rationale and the client goals, right? If the client's goal is to have a reduction in their symptoms and to reduce fear, and then, discussing with them like, hey, homework is going to be the thing that, and exposure is going to be the thing that really helps you. So, what are your goals and what do we need to do to get there? And really falling back on that, on the client stated goals and the rationale of how we get there.
Okay, so this person's asking, could you use an example of using SUDS going down over time during an exposure for expectancy violation? For example, the person thinks they will stay at a high level of anxiety the whole time they're in the situation, then they track SUDS to see if this happens.
Yeah, I think that could be fine. What do you, I mean, I think that could be fine. Yeah, if you are tracking SUDS, if the function of the tracking SUDS is to highlight that the feared outcome of staying at an elevated SUDS the whole time doesn't happen, then yeah, I think you could do that. Yeah.
Yeah,
It's,
yeah, I think
yeah.
you'd be asking, right, like how, right, that really critical question of duration, like how long do you think your SUDS will be at, whatever, a 90? Oh, I think they'll stay at a 90 for the whole hour.
Yes.
Okay, let's see. Yeah, I think that would be the violation there.
I think it's about differentiating the function, right? So if the function is to highlight that the feared outcome doesn't occur, that's fine. And it's not that the function is, do we want to see fear reduction for the purpose of learning in that session, right? Like it's differentiating what you're doing. Yeah, that was a confusing statement, but yes.
Okay, this is an interesting one. So if the initial learning persists and will become prepotent if active efforts are not maintained to inhibit it. So basically that old learning, new learning, right? So if active efforts are not maintained to inhibit the old learning, leading to we would think that leads to non-durable treatment effects. Is generalization of treatment over time simply a matter of encouraging clients to adopt a lifestyle where they regularly lean into fear and continually disconfirm fearful expectations? Do you have other thoughts about strategies to promote lasting fear reduction?
I love that question. Yeah, my short answer is yes. So after treatment, we would definitely want to kind of have some more education when we're doing like a relapse prevention session or something like that to highlight, yes, like these are things that you want to keep doing in your life, like keep leaning into the fear, right? Like keep leaning into the things that you want to avoid. Don't avoid them. Keep doing mini exposures, because if the client, when they're done with treatment, just goes back to avoiding stuff that they used to avoid, then yeah, treatment gains are not going to be maintained. So we would want that to definitely be something that they continue doing. And also, if their anxiety has reduced over the course of treatment, then they will be more likely to continue engaging in these things that they once avoided. What was the second part of the question?
Just any other thoughts about strategies to promote
Mm-hmm.
the lasting fear reduction and generalization?
Mm-hmm. I mean, I think that, you could do booster sessions if you wanted. That could be something where you have clients check in with you, maybe, once a month or something like that at the end of treatment. And also just, reinforcing that this is something that is a practice that they will likely need to keep doing over time. What do you think, Emily? I do booster sessions, and I do a lot of education around like making sure that avoidance doesn't creep back up.
Yep. No, I completely agree. Yeah. Yep. And that hopefully you're generalizing across enough context too during
Yes.
therapy that it does have that effect.
Yes.
I think you might have cited some studies, but not directly talked about them. But are there studies comparing the emotional processing exposures, like the habituation exposure, versus the inhibitory learning exposure, and then, or like a combination of those?
So Michelle Krask has a paper in 2008 that talks about the two and kind of like the differences and what they're comparing. There's not a ton of data published just right now about like actual like a study comparing the emotional processing theory to the inhibitory learning model. You can check out Michelle Krask's work. I mean, she's been working on this for years, and some of her recent papers are likely have some of that data. But the Krask 2008 paper that I cited, I have a bunch of citations at the top of my slides. And then also, particularly for OCD, there is a paper by John Abramowitz and Ryan Jacoby that I cited up at the top. I think it was 2016 that describes the two for OCD and compares the two. Yeah. I can also compile a list of references and you can post it if that would be helpful for everybody.
Sure. Okay. Okay, I like this one. If a client tends to engage in a lot of rumination after the situation, how can that be addressed in inhibitory learning? I sometimes notice clients will say that they couldn't tolerate an event because afterwards they ruminate for hours.
Okay, yeah. So I think, first, differentiating rumination from emotion, I think, is really important. I actually did this yesterday with a client. I had a client who was telling me that they were experiencing anxiety for 3 days straight, when in actuality, it was just that there was rumination that was going on for 3 days that every so often would then would lead to a spike in anxiety again. So I think like discussing the differentiation between what is emotion, what is rumination, that rumination is a behavior. And also, I think giving some tools for rumination would be pretty important too, right? Like giving some skills, like if you needed to, like mindfulness skills, right? How do you stay present in your exposure in the moment so you're not ruminating so much, or when you notice that you're ruminating, being very mindful in the moment. I hesitate to say using like a distraction technique, because that can also distract from what we're testing out. Yeah.
Totally. Yeah, I think I'll also add to that, and this might address another question. But sometimes with OCD, there's like the mental ritualizing part where they think like the rumination is the safety behavior, right?
Okay.
Where as long as I keep tracking this, or as long as I keep thinking about this, I'm protecting myself and I'm staying on top of it and I'm staying aware of it. So in those situations, I imagine you would want them to distract or do something engaging where they can't kind of engage in that process.
Yes. Yeah. Yeah. For OCD, that makes a lot of sense.
Okay, I have a client with PTSD and OCD. He's doing a great job with the exposures and tolerating his distress and recognizing that feared outcomes are not occurring. However, he's still experiencing intense distress throughout his day because there's still this maybe next time thought and intense anxiety about not being able to act on compulsions. We've been using DBT, distress tolerance, and emotion regulation skills to help him. Is this just an extinction burst we need to get him through, or do you have any other advice?
I really like the implementation of the DBT skills in there too. Let me think about that. It could be an extinction burst, I would say. And Emily, I think that you are more, sorry, I'm throwing this back at you, but you're well versed in OCD, I think more so than I am. But I think that this could be and this could be an extinction burst. And also with DBT, when you're talking about the distress tolerance and emotion regulation, I wonder if there can be some fact checking in there too, right? Some kind of like the fact checking about, well, maybe there's next time. So like how many times has it actually happened, right? So and doing so, and that could be like where some of the cognitive reframing could come in, or the fact checking in emotion regulation.
Yes, and I think with OCD, and I'm going to kind of we can do a quick sidebar, I know, because there's a couple more questions on that.
Yeah.
Right. So in OCD, but what if the intolerance there's an intolerance of uncertainty. So that what if next time will always be there, and you really want to address the reality, yes, what if that happens, using imaginal exposures, you know, using kind of more intense exposure experiences where, you know, maybe you have somebody touch the doorknob, lick, you know, put on their face, lick their hand, and now we're going to sit and do, you know, a 10-minute imaginal exposure where I walk you through dying, or, you know, what would it be like, you know, you're in the hospital and you're all alone and you're dying, and this is because you licked your hand. Because the goal of OCD treatment is to get people to understand there's nothing we can do to guarantee certainty. There's absolutely nothing we can do. So what you're tolerating is the uncertainty of that could happen. Yeah.
And I also think too that you can develop exposures around the intolerance of uncertainty, especially if the intolerance of uncertainty shows up in thoughts. So if, you know, there are thoughts like the what if, or, you know, like, yeah, what if I get sick? What if I get sick in 30 years? And then the exposure to that could be like, like, we don't know, maybe, you know, like you can actually do thought exposures where it's like, maybe you will.
Yep.
Sit and then tolerate the stress.
Yeah, maybe you get your family sick and they die. Like that's the imaginal exposure piece. And then, so a couple other OCD questions. Somebody asking about contamination exposures during COVID.
I saw that question.
Yeah.
That is an excellent question, because we now have some real threat out there, right? When we have OCD exposures. Yeah, I think, you know, we have to modify those exposures and also focus more on how the impairment in functioning is showing up. So if somebody, even during COVID, is like washing their hands like 7 times, right? Like washing your hands 7 times is not indicated. Even during COVID, it's not like washing your hands 7 times will make sure that you don't get COVID. So you can still do the exposures around, like, you can touch something and then maybe you wash your hands 1 time. Or, you know, doing exposures around things like, say somebody during COVID has the anxiety that, like, you know, if they wear their shoes in their apartment and like don't take them off immediately, like they're going to get COVID. It would be like, okay, well, maybe like wear your shoes around your apartment, like things like that. I think you have to modify them based on what we know to be true based on COVID, and then do the exposures in that way, because there still can be a huge impairment in functioning, right? With like contamination, particularly around COVID, like people can be washing their hands so much that they're raw, or like using hand sanitizer so much that there are cracks in their hands and stuff like that. Like that still isn't something that we need to do because of COVID. So we can still do
Yeah.
exposures on that.
Yeah, I saw a lot of really great talks at ABCT on this topic. And so exactly what you're saying, the kind of mantra they were using with their clients is go by the CDC recommendations, not the OCD recommendations, right? Like the CDC says wash your hands 1 time for 20 seconds. OCD is going to tell you to do it 20 times for 5 minutes each, right? So things like that. Jonathan Grayson has a nice podcast. I can't remember what platform it's on, but I think if you like go to his website, you might be able to find it. Or maybe it was on his Twitter. I don't remember, but he did a nice little talk very early in COVID about kind of what he was doing with his clients and taking on the idea exactly as you were saying, Dr. Loerinc, like what we know about COVID is it's like touch surfaces and bottom of your shoes and things like that. Like there's not a ton to suggest that that's gonna, they're like cleaning and stuff is gonna be that preventative. It's mostly this like, air breathing contact, whatever. So his kind of mantra with his patients is if it's in your house, like if COVID is in your house, it's in your house. There's nothing that you can do. If it's already in there, it's already in there. So doing all exposures in the house is everything on the house is in limits, I guess. Like you can do exposure to your garbage can, you can do exposure, to the bottom of your shoes. Because if it's in your house, it's already in your house. There's nothing that you can do to change that. And then from there, talking about, I think with a lot of my clients, we're kind of talking about like getting to a place of kind of moderate treatment effects and then like maintaining that until vaccines are all distributed. And then it's like, okay, come back to therapy, or if you're still in therapy, let's now go out and start exposures again and go kind of all the way to the extreme.
Yeah, cool.
So I know we're out of time. If people have to log off, I don't know, Dr. Loerinc, can you answer a couple more questions?
Yeah, sure.
Okay. If people have to log off, then we can get them the recording. Do you do a different exposure each week? And what are the guidelines on when to move on to the next exposure?
So yes, I do, and I do a different exposure each week. We really want to make sure we're varying contexts, and the only guidelines are, did they do it, right? Like, did they do the exposure? Did they do the homework? And if so, like, we're moving on. We can always come back to this exposure. We just want to make sure we're varying it up. And so, like I said, the only guideline there is like, did they actually do it?
Nice. Are relaxation methods incorporated?
So the answer is no. Relaxation methods are not incorporated. So initially we used, like, for example, we would incorporate breathing retraining, right? Into exposure treatments, particularly for panic. And that can be considered a safety behavior, actually. So we don't incorporate relaxation procedures because we want people to be anxious. We want them to experience the anxiety, to tolerate the anxiety, and then to see what happens on their own. So, no.
Nice. Okay, I think how do you apply the inhibitory learning model to fears that can only be targeted through role play or imaginal exposures? For example, a parent of a child with severe food allergy who worries that the child will consume substance and require emergency care. I think we kind of answered that with imaginal. Okay, are acceptance-based methods used to facilitate the tolerance of distress?
Acceptance-based methods used to tolerate distress. I mean, yes, right? Like, you're using acceptance-based methods to accept that distress is part of this, right? And that distress is going to happen. Do you have more to say on that, Emily? My short answer is yeah.
Yeah, it's very, And I think, using, different methods from ACT can be really helpful.
Yeah.
Oops. Hold on, let me just close the chat. Okay. In prolonged exposure for PTSD, do you now also suggest focusing more on the inhibitory model versus the habituation model? Should we continue with a significant focus on SUDS, or more focus on tolerating distress or taking surprise, either or, both and?
Yeah, I'm glad this question is being asked. So with PE, we're kind of doing a combination of both, right? So PE was developed by Edna Foa. So like it is the emotional processing theory that we're doing because we are looking at reduction of SUDS when we're doing the imaginal exposures, but we also do the inhibitory learning model a bit in there as well, because part of the exposure process during the imaginal exposure is helping our client to see that they can tolerate the distress associated with doing the imaginal exposure, and that their anxiety, their distress or anxiety while doing the exposure doesn't last forever. So we're doing both. And I think we need to continue doing both for PE, because PE is manualized, and we know that it works the way that it's developed. So I would say like you do both in PE. I'm doing PE with a client right now, and I am doing both. I focus on the reduction of SUDS and also the the learning that occurs with being able to tolerate the distress. When we do the in vivo exercises for homework, though, with our PE clients, I would say focusing more on the inhibitory learning would make sense. But with doing the imaginal, reduction of SUDS is also important. We know it works.
Yeah, for sure. I have one question. So you do your assessment.
Yeah.
And then do you kind of have the different categories of things to elicit or to create the exposure? Do you always pick like 2 things? Do you always pick 3 things, or does it kind of vary just based on where the person is at?
You mean for like picking from the assessment to put into exposure, or do you mean you're just doing the assessment?
From the assessment to put into the exposure. So for example, if it's like, okay, the situation is, going to a party with people, and then there's also like the feared thoughts and the feared objects. And so do you just do kind of one thing at a time, or do you do certain combinations?
It totally depends based on your client and what they are like ready and able to do. When I was in a training in graduate school with Michelle Krask, like we had a joke of like, the optimal exposure would be if you picked something from every single category and had it in the exposure. And that would be like the ultimate optimal exposure that you would do with somebody, but it's kind of unlikely that you would get there. So you can pick just based on what you think makes sense. And when you're developing the exposure list with your client, they're doing it with you. So you'd be like, well, how about this? How about we would do this? And you're like, okay, we could do this. So it depends on where they're at, what you pick.
Okay, that might be a nice way to. I love this model so much because I always hated making hierarchies.
Oh.
I just it was always just so like, oh, well, maybe this is a 60, or maybe this is a 65. And it was like just so hard to get everything on there. So it just makes it so much easier. But yeah, that might be a nice way to kind of do a little bit of a hierarchies. Let's start with just this one thing. Okay, now let's add in this feared thought. Now let's add in this feared object or whatever.
Yeah, perfect.
And I have one last question, and then we can wrap up.
Okay.
Sorry, keep you this way. Do you, from the start, with safety behaviors and safety signals, they're never allowed, or do you ever say like, okay, we can start with this and then slowly take it away?
So they are allowed. We just want to slowly take them away. So it would be part of the exposure list to have our exposures be in the absence of the safety behavior.
Okay.
Yes. Yeah, we don't just take it away from the beginning, because that would be like a really huge exposure right away.
Yeah, I mean, I have so many people, they're just like absolutely not willing to look up their cell phone or whatever. Yeah. Okay.
Yeah, you could do that on the exposure list. Like you're going to go for a 10-minute drive and leave your phone at home. Like that could be one of the exposures. And then you work your way up to never having the safety behavior or object.
Cool. Okay, well, I think that is all of our questions.
Cool.
So thank you so much, Dr. Loerinc Guinyard. And we will hope to see you all at our next training. All right.
Cool. Thanks, everybody.